Okay, well, Kevin and Kelly, thank you for the introduction. Thank you, everyone, for spending some of your Saturday afternoon with me. And I hope I'll be able to answer some of your questions, which I'm told are outstanding. So exciting, see how we get on. First of all, to everyone, thank you for my Dizzy Award this year. Sorry I couldn't make it to the Christmas meeting. We just had so many clinics. We were under such pressure. I couldn't get away from the clinical commitments there. But I've blocked out today, so here we are. So Kevin's just asked me to speak just for a minute or two to start with, not a lecture, just a couple of minutes on a few updates before we get into the important bit, which is the questions. And one of the things we're, of course, most concerned about is access to healthcare. And we're all aware of the huge pressure our GP colleagues are under and how difficult it is to access general practice. And it's no different in hospital medicine either. The government have just given us another big slug of money to run extra clinics at weekends, mornings and evenings in the hospital system to try and get waiting times down. But we're really in trouble because we've got the whole backlog of 18 months of pandemic and we're only allowed to see fewer patients than we were before still because of social distancing. So at the Leicester Royal Infirmary, for new ENT appointments, the management told me last week we're at 13-month waits for new appointments. And I know a lot of people are coming in to see me who have said they've been told it's an 80-week wait. So it's about 13 months, I think, for new ENT. For balance, it's a little bit better. We're at about 7 months on average, but it's very variable and it does fluctuate a lot. So I'm sorry the waits are so long. And for surgery, for balance surgery, for example, you're probably looking at over 2 years at the moment. It's almost,
God.
It's almost unreal how long the waits are. So we are doing our best. For life-threatening surgery, we're getting people in, but for balance surgery, it's just very, very, very long. Okay, so just a little update on what's new. Well, a lot of you will have been involved in these studies that I'm going to mention briefly here. So massive thank you to everyone who has been involved. And we're beginning to get the results out now. So the first one is the Meniere's disease registry, which has been an absolute spectacular success. And it was funded by about £150,000 of money from the Meniere Society, so a patient charity. And we've managed to recruit from 4 centres over 400 patients. In Leicester, at London Road Clinic and Leicester Royal Infirmary, we've recruited about 130 patients into the study. And undoubtedly, that will include some people listening today. So massive thank you. We've completed all the data collection. We're beginning to data analyse now. We've got 8 publications that are going to come out of this. So I've got a very busy few months ahead of me. But the first question that we wanted to answer is how likely are you to get Meniere's in both ears? So here's the first fact of the day. And at the moment, we're looking at about 19% of our patients with Meniere's are getting it in both ears. Now, we've got a fair amount of statistical analysis to do on this later on, but it's not the 50% that we used to quote. And I think there are reasons for that. So maybe that's very slightly reassuring. The second paper that I want to quote to you is a paper that, in fact, my son may have studied you on, I've studied with you, is Altered Visual Conscious Awareness in Vestibular Migraine. And those of you who had to fill in lots of booklets and things about yourself and then look at light spinning and dots flashing on a screen, you've produced the most spectacular piece of research I've seen in a very, very long time. And in fact, proud dad here, Oliver, my son, who ran the project, got awarded Young Neuroscientist of the Year for the work on this project. So it was a very emotional thing to me. I can tell you I was really trying to hold myself together when he got presented with this. And essentially what we've shown is quite extraordinary. And that is the more visually aware someone with vestibular migraine is, the more their brain reacts to light in a different way. It's very, very interesting. And we found that in the brain, there's a very linear graph. So those who have more severe vestibular migraine are more visually sensitive. And what's even more interesting, we did the same study in those with BPPV, and the results are exactly the opposite. So it seems somehow the migraine brain overweights visual information and gets worse and worse, whereas someone with BPPV, again, totally subconsciously, learns to underweight the visual stimuli, trying to suppress their symptoms. And it's because, the vestibular migraine is centered on one part of the brain. It's absolutely brilliant research, and it will lead on to lots of other things. I'm not going to say any more about that. And then the other one we did, which Oliver was involved in and I was involved in as well, was risk aversion in triple PD in persistent postural perceptual dizziness. And we found that essentially you are set up to have triple PD if you have it, like it or not. It's the way your brain is made. It's not anything you've done consciously, but it's the way you handle risk. So we found that people with triple PD were able to rationalize information that came to them very differently than those without triple PD. So in the card trick, if you did the card trick experiment, people without triple PD would think about it, get it wrong, and then would work out how to answer the question and get quicker and get good results. People with triple PD carried on doing random guesswork and weren't able to rationalize the answer. And we also found they had very strong positive urgency and negative urgency. These are slightly technical terms. And that is, they made essentially rash decisions when under positive and negative emotional stress. So what we're saying is that someone with triple PD handles information differently than someone who doesn't have triple PD. So those two rather complex papers are showing us how the brain works in people who develop more severe vestibular migraine and who develop triple PD. And so it gives us really good insights into how we might manage that going forward. Right, that's all I'm going to say about what we've done. I hope that wasn't too complicated, but what it says is we're making really good progress and it's really interesting. Kelly, over to you.
Okay, thank you for that, Peter. That was really interesting and useful. Okay, so we are going to kick start on my long list of questions, which look absolutely fabulous. So first up, we've got questions from Tracy. Tracy's asked, I've been advised to remove tyramine from my diet, with the logic being that dizziness is a migraine symptom, so to treat it like a migraine. Would you concur with this advice? And what's your experience of success rates with low tyramine diet in terms of symptom occurrence?
Okay, that's a brilliant question. And it's got lots of nuances to it. The first thing just to be careful of is that dizziness is a symptom, not a diagnosis. So you've got to make sure you've got your right diagnosis. So you can't change your tyramine diet to help dizziness unless the dizziness is caused by vestibular migraine. So if you're diagnosed with vestibular migraine, absolutely reducing tyramine is a good thing to do. And tyramine is a monoamine. You don't eat it. It's actually a breakdown product of other foodstuffs. And this then leads on to what is a really important list of dietary modifications patients with migraine and vestibular, not just vestibular migraine, with migraine should make. And remember that 40% of people who come to my balance clinic have migraine, often plus another balance disorder. So migraine essentially is in older, mature food. So the worst offenders are things like mature cheddar or Stilton. I know it's horrible, it's all the things you like. Smoked fish, cured meat, sausages, all of these things. So the older the food, and probably the more you like it, the more there is tyramine in it, and the worse it is for you. So if you want a bottom line summary, yes, tyramine is really important to anyone who's got migraine or vestibular migraine, and you should aim to eat a fresh food diet and a healthy diet and avoid the older and stronger and particularly processed foodstuffs. Now, there's a lot more we can talk about migraine diet. I have no idea if there are other questions on it, but I'll leave that one there. Okay, good, really good question.
Thank you for that one, Peter. Okay, next one then from Tracy is, what preventative actions other than diet change would you recommend to prevent dizziness onset?
Okay, again, the start of the question is, the answer is exactly the same. Dizziness has a multitude of different causes. So if it's BPPV, try and avoid lying flat. If it's Meniere's, avoid high salt diets and stress. If it's migraine or vestibular migraine, diet's actually really important. So you brought the issue of migraine up, and I think that for vestibular migraine, we often talk about the 6 C's. So again, it's what you love: chocolate, cheese, Chianti, red wine, citrus fruits. Now that's one that often catches people out. So that orange juice you have in the morning, or that tangerine or grapefruit you have, that's a really good trigger for migraine. We've talked about red wine, Chinese food, So all of these different types of Cs are big, the big triggers. And of course, the very biggest one of all is not this, it's caffeine. So this is peppermint tea. You wouldn't see me touching a caffeinated drink for love nor money. And I can tell you, I think I've changed more people's lives by telling them to stop drinking caffeine as they get older because you can't tolerate it, than I have any of the huge operations drilling out people's skulls and various things that I spend my life doing. So dietary change is really important. Living a healthy lifestyle, not skipping meals, having a straightforward go to bed at the same time, wake up at the same time, a regular exercise program, don't over-exercise, don't under-exercise. It's basically living a healthy, regular lifestyle.
Okay, thank you. So the last one from Tracy then is, to cure BPPV, I understand that there is a surgical option. It seems to be called different things depending on the mood of Google. We've all been there. But I've seen it mostly called posterior semicircular occlusion. Would this be something that you would recommend for somebody who has regular reoccurring BPPV?
Yeah, another brilliant question. So posterior semicircular canal occlusion surgery, posterior semicircular canal plugging surgery, those are sort of things we call it. And for someone like me, it's straightforward surgery. But to give you an idea of how much I do this, I operate in about 1 in 200 patients who come to see me with BPPV. So it's only a very, very small number of patients who have these symptoms that I operate on. And I'll get the vast majority of people with BPPV better. And someone who comes in with one-sided BPPV, I would expect to get 70 to 80% better at the first visit, 90% better at the second visit. But some of you on the forum will know that you're not in that 70 or 80% group. You're in the group who keep relapsing, particularly so if you have it on both sides. And what we would then do is try and do more aggressive maneuvers, CMONT maneuvers, regular maneuvers and so on. And we even have a chair to throw you around and bang you around, which has been uncomfortable, that we can do to try and get it better as well. We do suggest that you try and keep your vitamin D intake up. There's some suggestion that severe vitamin D deficiency can be associated with BPPV. I ask you not to lie flat in bed or on a deck chair. So no more summer holidays, lying on your bed, drinking glass wine, having a cheese sandwich and a piece of chocolate. It's all out the window. So you've got to keep yourself a bit propped up, but also keep yourself fit, because the time you often get BPPV is, if you've had a back operation or you've been ill and you've been laying in bed for a while, and then the crystals collect. Now, if you are one of those few people who will benefit from surgery, it can be life-changing. I've done the great majority of patients, we do just one side only, and I've done 3 of my patients have had it in both ears. And it's generally very well tolerated, but I'm drilling deep inside the skull, way down in here, brain above, brain behind, nerve to your face, so never damage that, but the face around it, and the balance and hearing organ there. So you can be very dizzy afterwards, some people are, and you can lose all your hearing. I've had one patient, that's 3% of my patients, lost all their hearing. And there's 2 other big series in the world literature, and both had dead ear rates of about 3%. So we don't know why it happens. Actually, considering what we're doing, putting bone graft into the balance organ with a 1 millimeter diamond drill, it's incredible that we don't see that more, and it's usually actually pretty well tolerated. So the answer to your question is, if you have absolutely severe unremitting BPPV that multiple treatments don't work for or don't maintain your lack of dizziness, and your life is absolutely ruined by it, then yup, surgery is life-changing. Otherwise, I recommend repeat Epley and CMONT maneuvers and lifestyle changes.
Brilliant. Thank you for that. So we're going to move on now to a question from Ella. Ella would like to know, she suspects her condition also has mental health links. Do many of us have anxiety, PTSD symptoms, and can you advise on treatments?
Yes, is a simple answer to that. A huge number of patients with dizziness do. And of course, it can be chicken or egg. So for most patients who have a chronic balance disorder, and by chronic, I mean one that goes on for a period of months, that induces an anxiety state. We're all human. I'll always say to my patients, we're not robots, we're human. And if you have any chronic illness, you will very likely to get a chronic anxiety state. And also, chronic anxiety and PTSD, for example, can lead to chronic balance disorder. Now, one of the hats that I wear is as a medical legal expert. For some reason, the courts and judges seem to want my opinion a lot. And in fact, my medical legal practice is fully booked till August. It's extraordinary. And these are really complex cases. And we have arguments from the claimant and the defense side. And usually these follow head injury and often minor head injury. And there is the argument of, is the head injury causing inner ear or brain damage? Is it anxiety causing the symptoms? Is it post-concussive syndrome? Or is it PTSD? And the various medical experts on both sides will argue the case until a compromise is made, which is the end of the case. So you can see that this is not an easy area. And we will spend several years on these cases often, putting the arguments backwards and forwards. So the answer to your question is there is absolutely no doubt that anxiety alone can cause dizziness. And there is no doubt that PTSD alone can cause dizziness. But often the trauma that causes the PTSD, if it's a physical trauma, can also cause injury to the inner ear, and also anxiety can come as a consequence of a balance and dizzy disorder.
Right. Thank you. So next up, we're moving on to questions from John. So John has asked, he says, I have a diagnosis of total, almost total bilateral vestibular loss. I have constant oscillopsia and feel drunk all the time whilst I'm moving. Also get occasional bouts of vertigo that last seconds. Is there anything I can do to improve my symptoms, like gaze stabilization and balance exercises, or will it not make any difference, or any medication that I should be on?
Right, well, I'm really sorry to hear that. So that's a really horrid position to be in. So for those who are not clear on this, a bilateral vestibular failure is where the balance organ in both ears isn't working. It's a bit like losing your hearing in both ears totally, but you lose your balance in both ears. And one of the classical symptoms of that is oscillopsia. Now, oscillopsia is where the world bounces up and down in front of you as you walk. So do you remember the old-fashioned camcorders? So when you were taking a picture of your kids running around, it was always bouncing up and down like this on the image, because they didn't have an image stabilization on it. One of the key reflexes in balance is the vestibular ocular reflex. So it's where your eyes and your ears talk to each other to stabilize the image. And when you're walking, in fact, your image is doing this the whole time because you're going up and down. But without you knowing it, your ears are moving your eyes in an equal and opposite direction to stabilize balance. And you can see it quite easily here. So to you, my eyes are moving side to side in my head. To me, my eyes feel like they're still. And it's because the fluid in my ear is driving my eye movements in an equal and opposite direction to stabilize the image. So if you lose function in both ears, you get this symptom of the world bobbing up and down, oscillopsia. And the other thing that can cause that is a stroke in a certain part of your brain. But if you've been shown to have bilateral vestibular failure, you're in a difficult position. It's likely, though, that you don't have total failure, because if you did have total failure, it would be unlikely you have short spins. Now, it's possible migraine is causing your spinning. That's true. But if that spin comes from your inner ear, it's most likely to be BPPV. That will be the commonest cause of short spins on a background of bilateral vestibular failure. So you can treat the BPPV with Epley maneuvers, Brandt Daroff exercises. You can do at home yourself. Those side-to-side exercises might help the short spins. Helping the oscillopsia is very, very difficult, and you've discovered this. So there are several ways you can go about this. You can do gaze stabilization exercises, and because it sounds like you might have a bit of vestibular function left, that will be absolutely the right place to start. So that's the VOR exercises, the cross on the wall, vestibular ocular reflex exercises. Now, they're called adaptation exercises because we're trying to make your brain adapt to its new scenario. If that doesn't work, we can use substitution exercises. And that's where Andrew Clements, I think, spoke with you over Christmas, is vestibular physiotherapist. He's an expert in this. And what we try and do is get you to use other systems, so your proprioception in your feet and your eyes, to try and help. Now, going forward, there's not much in the way of medication that helps here, but there are some other techniques that have been developed. There's a cap, baseball cap you can wear, which has got vibrators in it, and as you move, it tells you where to move your head. And Joel Goebel, Professor Goebel from St. Louis and Washington University has developed that. It's not really being commercialized. And the really exciting thing for everyone is vestibular implants. So most of us will have heard of cochlear implants, where you put an electrode into the cochlea in the inner ear. And for those who are profoundly deaf, suddenly they can actually hear well enough on the phone sometimes. It's extraordinary how good they are. Well, the companies who have developed those are also developing vestibular implants, where we put electrodes into your balance organ to try and get you balancing again. It's not been as successful as we hoped so far. There's no research going on in the UK at the moment because none of these companies are based in the UK. It's mostly in the States this is going on. But I'm hopeful over time we will be able to develop vestibular implants that will help you if you've got bilateral vestibular failure. But I'm sorry to hear that it's a challenging situation to be in.
John's also mentioned his age. I'm sure he won't mind me telling you as well. 51, he said he is, and he was wondering what the outlook is for him regarding the condition, because he used to be so active with it, but obviously the condition is severely affecting his ability to be like how he was.
Yeah, no, I get that. I mean, you're young because you're younger than your doctor. But you are, in vestibular terms, you're young. And if you are able to adapt, then your brain is young and plastic. In other words, it can change. And so absolutely, sort of 18 months, a couple of years of really hard vestibular physiotherapy is the right way forward. And if that doesn't work, then what we're going to have to do is try and get you to adapt your lifestyle with the substitution exercises, because this is one thing where at the moment we don't have a cure.
Okay. So next up, we've got a question from Sandra. Sandra has said, being on 50 milligrams of duloxetine and the TMS machine and having occasional occipital nerve injection, my lovely consultant, Professor Louise Murden, has signed me off, saying that's all she can contribute for me now. She said, when I felt my vestibular migraines were at an acceptable level, I should come off the duloxetine. I'm asking why. I assumed I'd be on it for life if it was helping. Can you comment on this, please?
Well, I can agree with you that Louise is lovely. She is a really very good friend. And I've known Louise since she was a young registrar, and I was president of the British Society of Neurotology. I've now, after 6 years, stepped down from that role, and Louisa is now president. And she's an audiovestibular physician, so I'm a surgeon. She's a physician. She's based in London, and she's very lovely, and she's very good at migraine as well. And she's given you a really big range of treatments: transcranial magnetic stimulation, occipital nerve blocks. All of these are sort of tertiary and sort of challenging migraine treatment. Now, duloxetine is an antidepressant. It's an SNRI. Those of you who have had antidepressants will be more familiar with the SSRIs, citalopram, sertraline, those type of drugs. The SNRIs are a slightly different group. Duloxetine is one of them, and the other one that I tend to use with my patients is venlafaxine. And these have slightly more anti-anxiety characteristics. They do have downsides in that they're slightly more difficult to come onto, and some people, you've got to go through a difficult couple of weeks feeling a bit spaced out, and they can be difficult to come off as well at the end of 12 months. Now, for triple PD, we normally recommend a 12-month course of these. For migraine, there isn't a set length of time you should be on them, but all good doctors, Louisa, me, whoever it is, will always try and limit the length of time you're on medicine, because every medicine has a side effect. And when you've got your condition stabilized, then it's not unreasonable to think about coming off them. And there's one concept I'd like to get over to you, which is, I don't know if it's a positive, I think it is, and that's the concept of the migraine march. Because your migraine at the moment will not stay the same as it is now in the future. So when you're a child, you might have torticollis, twisted neck from migraine. You might have recurrent abdominal pain, abdominal migraine. You might be travel sick all the time, it's migraine. Then if you're a lady, when you start having your periods, you start getting the headaches and you get those horrible migraine-y things during your adolescence. Then it might get sort of worse at university, and then somehow after that it gets better and worse with your periods. Then it gets worse when you have the kids and you're not sleeping. And then you come up to the menopause marching forward and you have a nightmare and your migraines are really terrible. And then you retire and go through the menopause and you sail off into the sunny uplands of retirement, etc. So that's the migraine march. So you can actually look back on your life and you can see how so much of your life has been molded by the consequences of migraine. So there's no reason necessarily that you'll have to be on duloxetine for all of your life, because your migraine may modify with time. And if you give the time on duloxetine also to adapt those other things, those dietary things, those sleep, exercise, and the other factors that we've talked about, maybe other stresses leave your life, then I think it's perfectly reasonable to come off it after a year or so when it stabilizes and see how you are. And if it doesn't work, you can go back on it. So I think she's being wise in her words.
Brilliant, thank you for that. Now, I think we've mentioned this just now, but you might have already answered it, but I'll ask just to make sure. So these questions are from Geraldine, and she's mentioned, was it venlafaxine, that one, yeah. And she's put that she's heard that can help with the combination of vestibular migraine and triple PD. Would this still be the case where anxiety is a significant contributing factor? And can you also say what other medication has given the best outcome with this combination diagnosis?
Okay, so yeah, that's a good question as well. So venlafaxine is my preferred option because venlafaxine has an anti-anxiety component. It's probably the best medication we have on our research for triple PD, and serendipitously, it also helps many people's migraines. So it's a really good one for all of those together. We don't have the research to tell us which is more effective, duloxetine, venlafaxine, or one of the SSRIs like citalopram or sertraline. So what we tend to do is I'll try and start people on a very low dose of venlafaxine and very gradually work up. If it doesn't work or isn't tolerated, then we'll flip over and we'll try sertraline or citalopram. But they are more geared towards triple PD than migraine. So you need to have the lifestyle and dietary modifications for migraine, but you can also add in migraine medications. So there's a whole range of medicines like amitriptyline, propranolol, topiramate that we use for migraine as well. That for some people who are very severely affected, you can actually have both medications. You'd have to speak carefully with your doctor, of course, about having two of these medicines together because all of them have a range of side effects. The amitriptyline, propranolol, topiramate, and so on, however, don't help triple PD, whereas the triple PD medicines can help migraine. So yeah, I think that venlafaxine would be an ideal starting place for you with that mix of symptoms potentially, if you can take it safely. Obviously, everything I'm saying today is generic. It can't be individual specific, and you must speak with your own doctors about it because there are contraindications to a lot of these medicines.
Okay, do you have any experience of dizziness increasing with increased medication, for example, with amitriptyline? And then when the dose is reduced, the dizziness not returning to previous levels? And are patients like this more likely to have a similar problem with other vestibular migraine or triple PD medications?
Okay, that's a complex question as well, but a very important one. And when I give lectures on dizziness, I talk about the 12 Ps of paroxysmal vertigo. And one of the Ps is pills, because medicines are a really common cause of dizziness. And there's a very big range of medicines we talk about. The obvious ones are things like the antihypertensive. So if you're on ramipril, amlodipine, any of these blood pressure medicines, it can make you lightheaded when you stand up. So we've got to rationalize your medicine and make sure your blood pressure is not too low. If you look at the medicine that's given to, I suspect every single person listening today has been given prochlorperazine, Stemetil at some stage, or Bucostem. I mean, it's a great short-term medicine for acute vertigo, but it's not a medicine to take long-term, partly because if you take it for too long, it can give you the shakes, it can give you Parkinson's disease symptoms. And secondly, it suppresses recovery from a vestibular disorder. So to get better from your balance disorder, you have to slightly stress the system. That's why we give you the exercises that actually your subconscious doesn't want you to do because it makes you feel rubbish. But if you take the tablets, it suppresses those symptoms and it doesn't allow the brain to adapt. So that can slow recovery. And there's a range of other medicines. You can have sonarazine. Again, I'm happy you're having it. Arlivert. I'm happy you're having these. They're slightly less strong sedatives of balance. Amitriptyline is given to a lot of people with a mindfulness element to their balance. And I think that because it allows you to function a bit better from a migraine perspective, it probably helps you adapt to the underlying balance disorder. And then the end of your question was, is it possible when I come off these medicines, I'll stay worse because of the medicine? not as a general rule. I mean, most of the side effects of medicine, I mean, anti-epileptic medicines, things like phenytoin, they can cause longer-term dyskinesias and strain, but that's really uncommon. That's a very select group of patients. But for most of the medicines we use with balance, except for the odd tremor with Stemetil, when you come off them, you're sort of back to square one.
Okay, brilliant. You doing all right?
I'm surviving. My voice is surviving. Is everyone else okay?
Yeah, we're doing good. We've got 5 more in this section, so you're all good. Then Kevin will chat for a bit. Okay.
I must say, the last session I did with you, it took me about a week to get my voice back afterwards.
Well, we're very grateful that you're here to help answer all of these questions. Okay, so next one up is from Sylvia. And she's put, I have been having a throbbing and pulsing in my head for many years. Originally after a boat trip, then diagnosed with vestibulitis, then ME. I've never had a diagnosis of MDDS. Could this be MDDS, as my head is continually moving, and where I can get a diagnosis?
Okay, so MDDS is Mailder-de-Backemont syndrome. And it's important to, there are absolutely people who suffer from this, and it's really horrid, the people who have it. Most of us have experienced symptoms of MDDS. So when we get off a boat, you still feel you're rocking, don't you? And you can sort of imagine there's a gyroscope in your brain. So when you get on a boat, you get your sea legs because your brain adapts to that rocking. And then when you get off the boat, that gyroscope, if you like, is still moving and you feel seasick. But our patients with MDDS, Mailder-de-Backemont syndrome, have this constant sensation. And one of the things that marks it out from other vestibular conditions is that it continues when you're still. So if you're lying in bed and you're sitting, it is often present. It's a different end of a spectrum. And because of that, it's much more likely to be central in origin than peripheral. And by that I mean, it's more likely to have a brain cause than an ear cause. Now, what you need to distinguish very carefully though, before we think about giving you a diagnostic label, is whether you have this very rare condition of Mailder-de-Backemont syndrome, or whether you have symptoms of Mailder-de-Backemont secondary to another problem, such as an inner ear problem. So it's perfectly reasonable and common to get a vestibular neuronitis or some other injury to the inner ear, and then develop these motion-induced symptoms. And they can then become tied up with emotion and anxiety and a whole range of other things, as we pointed out with those papers that I outlined just at the beginning of this afternoon. And then it comes quite complex looking at management. So I think that what I would say to you is, yes, you could have MDDS, but it's pretty uncommon. And what you really need to do is you need to go and have a full neurological assessment if you haven't already, and have balance tests doing, make sure there's no structural cause in your ear or in your brain or any other psychological cause that might be driving it. And then if all other avenues are exhausted and treatments for that are exhausted, then maybe look at pure MDDS as a diagnosis.
Brilliant. Okay, next up we've got a question from Norma, and she's put, she's been on holiday to Mauritius, that sounds lovely. So she's put, some years ago when my Meniere's was in remission, on a holiday in Mauritius, I tried snorkeling for the first time. It was an incredible experience, and I felt it as if a whole new world had opened up to me, seeing all the beauty underwater. I didn't suffer any side effects from the diving, and later on this year I hope to have the opportunity to try again. I'm, however, older and hopefully wiser, and wonder whether with long-term Meniere's, perhaps I shouldn't be snorkeling. What do you think?
Oh, absolutely not. Now, I learned to scuba dive in Mauritius as well. I agree with you.
Lovely.
I can recommend it to everybody. It's absolutely beautiful, and it's a long time ago, quite a stunning place. So snorkeling and Meniere's is absolutely no reason you can't snorkel if you've got Meniere's disease. I mean, the same rules apply to driving, don't they? That if you have drop attacks or you have Meniere's attacks without warning, you're not allowed to drive. And the same will apply to snorkeling. And of course, even more so to scuba diving, because the consequences of having an attack of Meniere's when you're scuba diving are absolutely catastrophic. Mm. So if you are someone who has fair warning of their Meniere's attacks, which is of course the vast majority of patients with Meniere's, I wouldn't stop you scuba diving either, as long as you're sensible about it. And as long as you're with a diving buddy who is aware of your illness, who sticks with you, you don't go crazy and don't go too deep, etc., etc. There is little evidence, no evidence that I know, that scuba diving will trigger Meniere's attacks. Now, I am aware of that the pressure change is said to be a potential trigger for Meniere's, even atmospheric pressure change, just as with migraine. But I don't see any reason not to scuba dive, no. The only thing is, if you are having drop attacks or unannounced attacks, clearly being out of your depth in the water is not a good thing to do. And of course, if you are one of the 20% of patients with Meniere's who also has BPPV, the position you get in when you're snorkeling and scuba diving might trigger BPPV as well, and that might be something else to think about.
Well, hopefully she'll have a lovely time. It sounds brilliant. Okay, so Kelly, not me, another Kelly, has asked this next question. So she said she started Meniere's type symptoms 18 years ago. Typical severe vomiting and dizziness, 2 to 3 hour episodes. She then developed tinnitus in 2011 in the left ear, and then from 2015 until 2020, she did not experience any symptoms at all other than the tinnitus. They all came back in 2020, but in a totally different guise. Sudden onset, short bursts of violent vertigo, which she had never experienced in the previous set of episodes. Is this likely to all be linked to the same condition, or could the change in presentation indicate a different condition? She's had only a 5-minute phone conversation with an ENT who diagnosed drop attacks as I was ending up on the floor, but that was because I was throwing myself to the floor, not being thrown. So I don't think from my research it was drop attacks. Just wondering if it is worth investigating. I do wonder if it might be something other than Meniere's now. So quite a few bits to that question.
Yeah, I think it's a brilliant question, and a really important one. And I'm really sorry that you only had 5 minutes on the phone. That just does not seem ideal for you at all, does it? Because, the very least, we need to see you check for BPPV and get a hearing test. So you really ought to be seen face to face without any question at all. Now, there is, again, several nuances to the question, because although you were diagnosed with Meniere's 18 years ago, about half of the patients who come to me with the diagnosis of Meniere's don't have Meniere's. So that's the first thing to say. Most commonly, those patients have vestibular migraine. So that's one possibility. And if you read the International Headache Society classification of migraine, which is possibly the most boring book in the entire universe, and it will send you to sleep, the appendix is on the diagnosis of vestibular migraine, and it allows for migraine attacks that last from seconds to days. And they absolutely change with age. So you could easily have 3-hour attacks with vomiting and vertigo 18 years ago and have short spins now. Alternatively, you may have had Meniere's before, and your short spins now, I suppose, could be Meniere's attacks, although it's unusual for Meniere's attack to be under 10 minutes. It could be BPPV, because 20% of my patients with Meniere's get BPPV. It could be vestibular migraine, because 40% of my patients with Meniere's get vestibular migraine. So do you see how they both go together? And it could be something completely different. You can get posterior circulation strokes. I don't know how old you are, but posterior circulation strokes can cause a cascade of short spins. It could be drop attacks, but you don't normally spin with drop attacks. You just fall to the ground without any warning, and they don't last 5 minutes. So it doesn't sound like a drop attack to me. So you are someone who absolutely needs working up medically, in my opinion. You need to be seen. You need to be properly examined for BPPV. You may need a head scan. You may need a full panel of balance tests, I would have thought, to try and get to the bottom of this. So I think I'm a little uncomfortable with your presentation, and I would go and seek medical referral if I was you. Again, I'm not really meant to give personal medical advice on this type of forum, but I think it's not unreasonable to guide you to seek further advice with the presentation you give. And the other thing I have to tell you is you need to think very carefully about the DVLA, because if you're getting attacks of vertigo without warning, you probably can't drive, and you probably should be informing the DVLA. But again, I can't guide you on that on a personal basis. You need to talk to your doctor about that. And I'd refer you to the DVLA website to make your own judgment.
Brilliant. Thank you for that, Peter. Okay, next up we've got a question from Catherine. She said that she's afraid to get on a plane, train or boat because the movement could cause another condition to start up. She has minor hearing loss in her left ear from labyrinthitis and has been diagnosed with vestibular migraine. Should she stay put?
I guess it's difficult. No, I don't think so. I think you should, look, we all have one life. And I think you've got to enjoy it. And I think that train, planes and automobiles, etc., are actually vestibular physiotherapy. They stimulate you. And my strong recommendation is always go and try and enjoy life, because, you know, we're all going to be old one day and we're going to look back and we're going to wish we had. And, you know, I accept that with vestibular migraine, travel can make you feel pretty queasy and yucky. If you've had a labyrinthitis in the past, that's a fairly big hit to the ear. But again, there's absolutely no reason you shouldn't travel sometime after labyrinthitis. And what I would do is, depending on the distance you're traveling, if you're doing long haul, I would go and see if you can get a nice GP or doctor who'll give you some diazepam, some Valium, or a similar medicine. They may or may not give it to you, but just to let you sleep through the flight. That's a good thing to do, as long as you're not driving at the other end. Or if you don't want to do that, you can use a drug like Cenarizine, Stugaron, or Arlavert, which is a mixture of Cenarizine and another antihistamine. And they're basically seasickness tablets. And if you dose yourself up with those, don't drink alcohol or caffeine on the flight. Maybe put a blindfold on. Put some headphones on with some nice gentle music on. Put a blindfold over your eyes so you're not getting visual or auditory stimulation during the travel. And if you are going on a flight and you get really stressed by crowds, book into a business class lounge. Pay the £25. Go and, well, actually, business class lounges are really busy now as well, aren't they? But try and find a quiet place and maybe persuade your other half that you really ought to be traveling business class. I'm just trying to be helpful. And, you know, just enjoy life and do it.
I think also, Catherine, just from my experience with, because I was concerned going on a plane, if you ring the airline and explain that you've got this condition, they're really helpful, and they were able to sort out things in terms of bypassing the check-in queues and the security queues, and making sure that you boarded first or last when you were on the plane to kind of take out that kind of tension. So just speak to them. They were really helpful when I did it, and I would definitely recommend that as well myself.
That's really helpful, Kelly. I've not actually recommended that before, but that's a really, really good point.
It was just
I'll tell people
that we had, because I was worried about being separated from my husband on the flight, and if I had an attack, how I would be. So rang them and they put in all sorts of measures, all complimentary. We didn't have to do anything, and it made the journey so much easier, particularly when we had a connecting flight as well. Because trying to get through, you know, the busy airport in a tight frame would have been really challenging, but they were really, really good. So try that. Definitely. Okay, last question before we hand back to Kevin for a brief while is from Linda. And Linda said she suffers from bilateral vestibular hypofunction with oxalopsia. And I find that when the atmospheric pressure is high, my balance and visual problems get significantly worse, which debilitates me completely. At this time, she also suffers with constant nausea and the feeling that her ears want to pop. It took 18 months to be able to walk for a mile with a stick, but when the pressure is high, she can't even walk to the end of her drive. Is there anything she can do to alleviate these increased symptoms, which she believes are due to the high pressure? She's not on any medication currently, but was wondering if prochlorperazine tablets may help. Any help or advice would be greatly appreciated.
Okay, well, thank you for that. You're in a really difficult situation. I think the first thing is prochlorperazine won't help. It's not the medicine I'd recommend for you because it's quite a strong vestibular sedative, and it's not one I want you taking long term because, as mentioned previously, if you take it for a fair period of time, you can get the Parkinsonian shakes and so on. Pressure change we've touched on already this afternoon. There are patients with Meniere's and with vestibular migraine who do seem to be genuinely sensitive to pressure change. It's pretty difficult to know what to say. I would have thought that you've got more than just oscillopsia here from bilateral vestibular hypofunction. I wonder whether you've got migraine as well, or some other condition that's contributing to it. And I don't, unfortunately, have anything really helpful to say, because it's going to be a matter of actually establishing all elements of your diagnosis, whether there is triple PD present as well, persistent postural perceptual dizziness, whether there's any migraine present, whether it is purely bilateral vestibular failure, and trying to get the whole care package for you with that. And that might include vestibular physiotherapy, and we've talked about the two different types of substitution and adaptation, whether a CBT might be helpful for you to try and overcome the pressure change, whether mindfulness might be helpful for you, and these type of things in that setting. And I actually saw, I don't know if she's allowed to speak because we've got a 2-minute break. I think I saw Michaela's name pop up. Michaela, are you here, Michaela? I'm just going to have a quick flick through. Yeah, Michaela is here. Michaela, am I just through the 2-minute break while I run off and get a drink? Is it, Kevin, is it acceptable for Michaela's going blank now? Sorry, Michaela, can I just bring you in on that point? Are you happy just to speak just for a minute or so on mindfulness and so on, and on stress management, hypnotherapy and so on? When our patients find it really stressful in certain circumstances, is that, I haven't asked you this, but is that a reasonable question to ask you? Or am I going to get in a lot of trouble at work next week?
That's what you're in it for it now.
Okay. Is that all right, Michaela? Just give us a minute on that element.
So certainly anxiety will cause feelings of dizziness. It will make your heart rate pick up. It will make your breathing change. Your breathing becomes shorter and shallower. It can give you the jelly legs. Makes your stomach turn up in knots. And depending on what symptom kind of you focus on more, you'll notice more. So people with balance problems will tend to be very focused on the lightheaded aspect of anxiety symptoms that they experience. Helping reduce the anxiety response can make a huge difference to how you then deal with your vestibular symptoms. So it's very easy to get into the cycle of you feel bad with your balance, which makes you more stressed and anxious. The more stressed and anxious you get, the worse you're going to feel with your balance, and makes you more stressed. So it builds into a cycle very, very quickly, very, very easily. Now we can deal with the vestibular side of things with the vestibular physiotherapy, with medication where appropriate, and those kinds of things. But it's really important to acknowledge the anxiety aspect, because it's normal. It's your brain's way of trying to look after you and to prevent you from putting yourself into what it believes is potentially dangerous situations. Your brain wants you to live. However it happens, it wants you to live. And if that means making you avoid going out in certain weather conditions, it will do so. So things like mindfulness is really, really good by helping you to focus on actually what's happening on the here and now, and not focusing on the, well, if I go out, what if I feel this? And if I feel this, what happens then if I fall into the road? Or if people see me, they're going to think I'm drunk, and are they going to tell people this and that about me? The stress level builds up. By focusing on the, just what am I doing now? And controlling your breathing and altering your breathing back to a normal, settled pace can alter how you feel completely, and then put you in a much, much better position to be able to say, okay, I am quite safe, I don't feel good, but I'm safe and I'm okay at this moment, can then change things. Now, I'm going
to stop you there and say thank you. That's exactly what I wanted. And look what my wife bought me for Christmas. An Apple Watch with mindfulness on it. So I have, whenever my watch feels that I'm working too hard, it buzzes and it says, should we have a 2-minute break? Michaela, thank you. I'm really sorry to drag it. Michaela, by the way, Michaela Burton is a senior vestibular audiologist, and a number of you will have met her being tested and treated. So Michaela, sorry to put you on the spot, but thank you for that. Okay.
Brilliant. Thank you for that, Peter, as well. And yes, thank you, Michaela. Kevin, I am passing this over to you for a few minutes whilst I go and sort myself out, and Peter has the cup of peppermint tea refill.
Yep, I'll go and do that.
Yes, definitely. We'll back in 2 minutes.
Brilliant. And can I say, much to my amazement, Kelly and Peter are on schedule. We're normally about 15 minutes behind, so we're doing very well. So just a quick break. Let the two of them pause for breath. Brilliant questions, by the way. It never ceases to amaze me. We're into year 3 of this sport group, and I still learn so much at every meeting. So well done for asking them, and thanks, Peter and Kelly. Just a quick interlude. I'll start with controversy. Peter knows this one anyway. I still live on red wine, coffee and chocolate, and I have many heirs. So just the only reason I mention it is, yes, I had to do what everyone else did and deprive myself of the things I love. But gradually I started experimenting back onto various things, because one of the great beliefs I've got, no matter what your condition, whatever adversity, quality of life matters so much. And if you can get back to doing some of the things you love, whatever that is, it's great. But obviously just do as and when you feel brave enough to try one thing and see what happens. But I'm well stocked on Rioja, so I'm enjoying things that way. Reason I wanted to just have a chat was update you. Some of the new members might not know this. Everyone else thinking about emails. We're now running some work groups with members on actually helping the group website get better information. And I've just run you through the topics we're on. We've had lots of volunteers, but we always welcome others if they want to join in. And what we're aiming to do is put on our website information you won't normally find anywhere else. So, for example, the awful process of claiming disability benefits if, due to balance conditions, because it's no secret, I don't think our governments alone, most countries don't like giving out benefits and make the process as difficult as possible, to an extreme where it appears most unfair. So we're trying to offer advice on how best to work through that system. Likewise, we're going to be putting up pages on dealing with anxiety and depression, which sadly is oh so familiar to most of us with balance conditions. And just mention again that if you're lucky enough to be treated in the Leicestershire NHS catchment area, if you do go to the NHS Balance Clinic, you can ask to be referred to the health psychology unit that will offer free counselling and assistance on overcoming anxiety and teach you new ways to deal with it. So that was a breakthrough last year. Other issues we're going to be dealing with is employment and balance. Again, very sadly, but I guess predictably, a lot of people will encounter a serious balance condition, wonder what the heck is going on, life's turned upside down, you're at the very lowest point in your life, and what happens? Your employer, some of them decide they no longer want you around. They can't do that. You are protected by certain rights. So we just want to help people when you're in that awful place to try and ensure that employers understand what duties, responsibilities they have to you. Balance issues with family and friends. Might say, why this topic? Well, it's very difficult unless you experience a balance condition yourself. It's extremely hard to explain why this significantly changes your life in a bad way. It's very difficult to show anyone, and the fact you don't walk around with a plaster on your head or any other part of your body, a lot of people go, you look fine. So even with family and friends, we're trying to find what our members' best practices, what have they found that's worked, and share that advice. Because what you do need is a support group around you that starts obviously with your closest family and friends. I know a lot of my friends, 17 years on, still think my balance condition is more akin to being dizzy on a merry-go-round or having 1 pint too many. So it's very hard for others to understand how it can change your life. This one for the men, you'll see that there's a majority of ladies on our Zoom today. We're trying to find ways, strategies of reaching out to men, because as many men suffer from balance conditions as ladies. But an example from myself, before the days of SatNav, if ever I was lost in my car, I would never pull over and ask anyone directions. And that's it. I call it a man thing. It's partly, I think, men are less likely to say, yes, maybe I could get help, or worried as I was originally about being defined by an illness. But again, we're trying to find ways of reaching men. We want to translate some of our web pages into other languages. We have been contacted over the years by people in other countries. There is no life on the level in other countries. It's just not there for people. So we want to share the information if we can. Hearing issues related to balance conditions. Again, that seems to be a common theme where, for example, I'm deaf in one ear and just have roaring tinnitus. So again, we want to get into specific solutions that help people with various balance conditions. And the final work group we've got is talking about best practice with retirement, travel and leisure. So people that have, again, already ahead of the game here, you've had years developing your best strategies and tactics. We just want to share those on our website with everyone else. Any of those topics you think you can add some advice, experience or insight, just email me. All we do then is I contact you separately, and we look to get information from you or your story, and then share it on our website. Almost finally, I have to mention this every meeting, especially for the sake of new members. We run an opt-in facility called Member to Member, where you can, if you want to, have your email address and or phone number shared with other members who have opted in. So it's not with all members, it's only with others that have opted in. The great thing about that is you can discover brilliant new friendships. You can end up conversing, talking, emailing with people who've got almost identical situation to yourself. Before the pandemic, and hopefully afterwards, it'll be an opportunity. If you live near to each other, you can actually meet up for coffee, or Professor Ray would say mineral water. But I just encourage you to consider opting in. Those that have done it, and it's roughly about half the members, we get nothing but positive feedback about how great it's been talking to other people. One last thing, a new thing then, and again, you'll find it's a recurring theme with me. I'm always asking for help. We have quite a few new members join throughout the year, and current members will be aware we do something called Balance Buddies, where there's 6 of us. You can contact us at any time and just put questions to us, or just chat about how you're finding life, whatever. They're balance buddies. What I'm really after is a few members who wouldn't mind volunteering to be new member buddies. And all that would entail is, when we get a new member, just emailing them initially and introducing yourself, saying, hi, can we help you understand how to get the best out of the group, how it works, and just have a chat. And it's just a way of someone other than just myself all the time sort of saying hi to new members. Anyone who wants to volunteer for that, email me. We would have a quick separate Zoom where I just run through what we try and do with new members. But as you all know, especially those who've been around, the more you put into something, the more you normally get out. So attending the meetings, but also discovering what resources are on the website, and importantly, knowing that you're just not alone, because that is a recurring theme. When people join, they're so relieved to find that it's not just them. This is quite normal. So that's it from me. So please don't hesitate to offer help. And remember, we all understand about help that with our conditions, we don't know from day to day whether we're up to helping. So that's quite understood. So that's it from me halfway through. I was saying, Kelly Peter, you're doing very well. We are on schedule, unbelievably.
Okay. Dream
Yes.
team now.
So what we're going to do now is part 2 of the questions. If we do get to the end of that and have some time, we'll take other questions live and discuss other things, but we will just see how it goes now.
Yeah.
So back over to you, Kelly, and thank you, everyone.
Are you ready for part 2, Peter?
Absolutely.
Fabulous. Okay, so first up this second half, we've got questions from Debbie. So Debbie would like to know, is it beneficial to see a neurologist and an ENT consultant for constant dizziness?
The answer is it depends what the cause of the dizziness is. So we generally recommend seeing an ENT surgeon with an interest in dizziness, and if you're going to see a neurologist, see someone with an interest in dizziness, because they're both fairly broad specialities. Now, as you know, I'm super specialist in dizziness and balance and all things ears, but not all ENT surgeons are, certainly, and similarly with neurology. So what we're trying to do nationally is get local balance centres. I don't particularly mind if you see a neurologist or an ENT surgeon or an audiovestibular physician, as long as they've got the expertise to manage balance conditions, because balance is slightly different to most conditions. If you're going with a fractured hip, you're going to see an orthopaedic surgeon. If you're going because you've lost your vision, you see an eye surgeon. But dizziness covers lots of different specialities. So if you've got chronic dizziness, it can be vestibular, your ear, it can be your eyes, it can be visual, it can be psychological, it can be central neurological in your brain, it can be peripheral neurological in your sensation, it can be caused by shortness of breath, cardiac disorders, endocrine, thyroid, anemia. Did you see? It can be almost anything. So this is the problem which has actually recurred during the questions. It's very interesting, isn't it? That dizziness is not a diagnosis. Dizziness is a symptom. So the thing to do is go to someone who knows what they're talking about, and get a diagnosis from them if possible. And if you come to me, I will give you a diagnosis if it's within my remit. And for the majority of patients with vestibular migraine, I'll be able to treat you, or with migraine, I can treat you. And if I find a neurological problem, then I'll refer you over to a neurologist. And I'm in the very fortunate position, I don't know anyone else in the UK who's done this, is that for 18 years, I've run a joint neuro-otology clinic once a month with Peter Critchley, who's very sadly retiring in a month or two. So I'll break my heart when he goes. But we see just the most extraordinary patients and the most extraordinary conditions together in our clinic and work together for our patients. So the answer is don't see both at the same time because you'll just have things repeated. Try and get your GP to guide you. Is this more likely to be an ear or vestibular migraine? Come and see me. Is it more, have you got tremors and weakness in your leg? Maybe go and see a neurologist. Have you got heart palpitations and you get dizzy when you stand up? Go and see a cardiologist. And then get guided between people.
Brilliant. Okay. She's also said that a few years ago she was prescribed clonazepam by a neuro-otologist for occasional use. Is there a drug she could take every day to help contain dizzy symptoms? She's currently not in the case of a consultant as she has moved area recently.
Yeah, I mean, clonazepam is a drug we do use occasionally. It's actually licensed for panic disorder is the main indication for it. So using it for dizzy spells, and it is for dizzy spells, is off license. But we absolutely do use it for some of the paroxysmal, the episodic dizziness. It's not used that often though. The question, unfortunately, is unanswerable. And the reason is dizziness is a symptom, not a disease, not wanting to repeat myself. And it totally depends what the cause of your dizziness is as to what medication we'd recommend. So, if it's triple PD, then you've got the whole range of SSRIs and SNRIs. If it's migraine, it might be amitriptyline or propranolol or topiramate or a whole range of drugs there. It's BPPV. You could take something like clonazepam if you just have the very occasional one, but treating it with an Epley or Brandarif is much better, etc., etc., etc. So you need to get a diagnosis before we decide what medicine to use. And as a rule, we try and avoid medicine.
Yeah, makes sense. And final point from Debbie then is, why does stress and worry make symptoms worse?
Oh, absolutely they do. And again, it's a vicious cycle, isn't it? You get dizzy and you get stressed by them. And in a way, the two of the papers, this altered visual conscious awareness I talked about, and risk aversion in PD I talked about at the beginning, give us a hint as to why this is. And I'll give you, I don't know if it's helpful, I'll just give you an example of one of the concepts we have from the research. Essentially, your brain works on a heightened sense of awareness. So if you're frightened, you get this fight, fright, flee reaction where your adrenaline comes up. You're much more aware of everything that's going on around you. Now, in many of our patients who have chronic dizziness, they're on a state of chronic heightened alertness. So that's why you get brain fog, chronic fatigue, can't remember things, you get stress, all of these things together. And just to try and give you a bit more insight into it, I want you to think about your eyes, your ears, and proprioception, so the sensation from your feet. And each of those three areas of sensation are sending signals to your brain, to the balance part of your brain, along, let's say, copper wires. Now, those three elements are then balanced in the balance part of your brain, which tells the rest of your body what to do. But when you're in a state of anxiety, the signals are amplified. So that signal that comes from vision, rather than saying, yeah, okay, there's someone moving over there, a little bit of motion outside me over there. Look, look, look! Brain, be scared, there's something really happening over there. And the brain goes, what? And you're on this heightened state of alertness and anxiety. And that then in turn causes anxiety, and that in turn causes chronic dizziness. And that's why giving some medications that can sometimes reduce that, for example, the SSRIs and venlafaxine and triple PD, which suppresses some of those stimuli. This is how we could conceptualize it. Can actually make a really big difference to patients in that setting.
So moving on to a couple of questions from Simon. Simon asks, has there been any recent advances in the understanding of and treatment for vestibular migraine beyond the current diet and supplements? He seems to be able to manage his through both of those, but wonders if there's been anything else further in terms of recent advances.
Yeah, I mean, it's a good question. It's a huge question. I mean, our understanding, we're chipping away at it. And we have a little bit of a big American grant looking at it in Leicester, and I talked to you about some of our own research here, which I think is really interesting. Actually, it relates very much to this visual hypersensitivity that many people with migraine have. So you have the migraine attacks, but you also have a background migraine experience. You are a migraineur. You either are or you aren't. And it changes the whole of your life in so many different ways. And yeah, we start with diet and lifestyle change, and all of those little nuances I talked about, whether it's not skipping meals, sleeping properly, getting the right amount of exercise, taking stress out of your life, getting enough sleep, all of those things. And then we can go through medications, and there are always more drugs being added to the list, whether it's candesartan, or there's a whole range of drugs that we try, and we find now that the SSRIs can also be quite helpful in migraine, as well as the ones you may have tried already, such as amitriptyline and topiramate and propranolol and so on. So there's a range of different medicines we can use. There is transcranial stimulation and magnetic stimulation. You can have occipital nerve blocks. You can have Botox injections into your face to try and neck to try and relax the muscles there. And there are some new migraine drugs, biologics, which are very expensive. And those with severe migraine may be eligible for those. They're only prescribable through neurologists, to my understanding. And what you'll see is that the literature, the science, is very much based on classical migraine headaches, because that makes up 90% of migraines. But as everyone here knows, 10% of migraines are vestibular. And you don't have to have a headache, in fact, to have the migraine. So the drug companies and researchers will, of course, concentrate most of their work on the vestibular migraine. Now, we are looking at maybe trying to get funding of some drug trials in vestibular migraine in Leicester, but it'll need a multi-million-pound research investment, and it's fantastically difficult to do this type of research. I mean, we're actually recruiting vestibular migraine patients at the moment. I think we just need three more to complete the current study that we're doing, but it's really hard getting pure symptoms to make the research go forward. So I think the answer to your question is because 10 to 15% of the population experience migraine, and because it's so debilitating, there's a huge amount of work going on. But I can't, other than these new biologic medicines, which are coming out, I can't give you any particular sort of wonder discovery.
Just watch the space, I guess it sounds like, with that one. In terms of, you meant to touch on research. The other part of Simon's question is that he understands that there was some research funding at the University of Leicester, which he put his name and details forward, but hasn't heard anything. Has the programme been progressed, or has COVID got in the way and put the brakes on it?
Well, firstly, thank you very much for putting yourself forward for it. I don't know which project it was. We've had a lot of projects ongoing. With the Meniere's projects, we've now completed recruitment. The intratympanic injections for Meniere's we've completed. We've done five studies on that, completed that. And the Meniere's registry database, we've completed recruitment for that as well. There's a tinnitus study that I've been doing with biotech, NASDAQ-listed biotech company in California, and that closed recruitment last week. And we had some regulatory problems getting that through in time, so we didn't get through quickly enough on that one. The most of the migraine studies we've just about closed on. There is one, I mean, we've always got lots more doing with migraine. And if you have pure vestibular migraine and nothing else, so you don't have BPPV or Meniere's or anything else, and it's me or someone else who has diagnosed your vestibular migraine, you know, a senior balance specialist, we would, and you live locally, we still have 3 or 4 people we want to recruit. It's a very quick study, this one. You'd only be with us for about 15 minutes, and if you're local, we can get that sorted for you. So maybe if you want to drop your details to Kevin, but it has to be pure vestibular migraine. So vertigo attacks definitely caused by migraine and with no other balance problems. And now you begin to see the difficulty with research, because most of my patients with vestibular migraine will have something else with it. And it's actually quite difficult to get pure patients for the research.
Yeah, definitely. But yeah, definitely hand those details to Kevin. So next up, we've got a question from Sue. She is due to have a VEMP test in March to confirm canal dissonance syndrome. That one, yeah. And she's not to have caffeine nor medications such as Sturgeon and Stemalatin.
Yeah.
That's the one, yeah. I've recently been prescribed amitriptyline for my migraines. The question is, can I still take the tablet prior to my test?
Yeah, okay, so superior semicircular canal dehiscence syndrome, or Lloyd syndrome, minor syndrome, sorry, it is where the bone at the top of your ear, superior semicircular canal, you don't have bone between that and the brain. And you get a range of really weird symptoms. So you can hear your eyes move in your head. And in the past, doctors would go, well, actually, it's a real thing. Superior semicircular canal dehiscence syndrome. And we can either go in through the brain or through the ear, depending on the anatomy, and we can put a bone graft on top of it. And you get these patients with this get autophony, so they hear their internal sounds. It's really unpleasant. And if they try and strain or lift, spin and fall over, there's a range of stuff. So coming off those other medicines is okay. I wouldn't see any problem being on amitriptyline. Michaela, have you got any problems with amitriptyline and VEMPs? Because Michaela does the test.
Amitriptyline, we wouldn't have a problem with. It's medication prescribed to suppress vestibular function. We would have problems with Stemetil, cinnarizine, beta-histine, prochlorperazine, those kind of things. Don't take them because you can give us warped results, which isn't going to help you. But amitriptyline, that'd be fine.
I agree, and I usually leave.
When there are conditions, please take it.
Yeah. If you're on absolutely, your normal medicine, take it. Absolutely, we don't want you passing out. But as long as you're on a low dose of amitriptyline, if you're just taking 10, 20, 30 milligrams, it's absolutely not a problem at all.
Brilliant, and thank you for that, Michaela, as well. That was helpful. So a question from Christina. She says, are you aware if there is any plan to add on to the GP training curricula something around balance problems whilst doing ENT or neurology rotations?
Well, good question. Now, not only was balance dropped from the training curriculum, but so was ENT.
Oh, wow.
The whole of ENT. So GPs didn't have any ENT training in a number of units. And at the moment, they get 1 to 2 weeks with us shared with eyes. Now, the head of the medical school here, Richard Holland in Leicester, he's a really good guy. In fact, we were flatmates in Oxford, so that was quite good, quite useful link there. And we've got ENT back, and I try and get my medical students in, and they will at most get 1.5 day in their entire training on balance. And given that 30% of us will be dizzy before the age of 65, and it's the commonest reason to see a GP over the age of 75, that's a problem. So I've just stepped down. One of my other hats was President British Society of Otology, which I've stepped down from a week ago. And, the pressure's come off, that's good. But one of the things we did was we have an academic secretary who's reached out to GPs, and we're trying to do a lot of training on that as well. And so I do run a lot of courses, trying to train GPs in a lot of vestibular stuff. Yep.
Okay, next up we've got a question from Georgina. So Georgina is currently pregnant, and the dizziness, so vestibular migraine and triple PD, has been slightly better throughout the pregnancy. But she has heard that after having the baby, she's likely to get a lot worse due to the drop in hormones, sleep deprivation, etc. Is there anything that can be done to help prevent this or help cope with?
Well, congratulations, first of all. And pregnancy is a funny thing, in that some of our patients with migraine and Meniere's are just magnificently better during pregnancy. And some people have a really rough ride, and the same after pregnancy. Some people are fine after pregnancy, so don't live in fear that you're going to have a really bad time, because some people seem to do really well, but some people really struggle. And you're absolutely right that sleeplessness is one of the issues. And it's not just ladies. I mean, chaps, I'm slightly tongue-in-cheek here, just not built for that, and seem to really struggle after. And I get lots of men in their early 30s coming in and say, I don't know why I'm so dizzy with brain fog. And they've got 2 young children. And, running a family is absolutely exhausting. So it's a fairly trite answer, but, share the burden. Make sure you look after yourself. Try and get some sleep. And it is totally unpredictable whether you're going to be worse or not. But have a good diet. Don't skimp. Don't skip meals. Don't try and keep yourself up with caffeine. Drink well, eat well, have a little bit of you time. It's all very, very easy for me to say, but it's really about trying to look after yourself, and don't dread it. Just enjoy it, because it's such a wonderful, wonderful time.
Definitely. Okay, so next up we've got one from Gail. Now there's quite a bit of information here. So she's got a working diagnosis of severe acute vestibular neuritis with secondary vestibulopathy. She had an MRI brain scan arranged, and it was normal, but vestibular investigations were not normal. Calorific testing showed strong responses on the left, but none on the right, suggestive of significant right vestibular deficit. Audiometry was normal. In 2017, triple PD was mentioned. And apparently you suggested amitriptyline or SSRI, but she wasn't keen. No further progress, but she has managed to live with it. During lockdown, when she was less active and worked more on her computer, her balance has deteriorated, and now not steady enough to play bowls, which is her main hobby. She believes she's still looking for a silver bullet in the absence of that. She'd simply like to know if there are any advances in terms of possible treatments.
Yeah, well, I'm sorry to hear of your ongoing symptoms. And if you had an absent caloric on the caloric test, it means you've had a really big hit to your inner ear. So you've got a big deficit that needs correcting. And vestibular physiotherapy is the best way forward. And, you need a good 18 months of really full-on vestibular physiotherapy. But as we've heard, some people's brains respond differently to that type of injury and develop symptoms like triple PD. Now, with triple PD, if we do the vestibular physiotherapy alone, we get a reasonable number of our patients better. But we need other therapies with it as well. So CBT, we've mentioned cognitive behavioral therapy, and psychological supports can be very helpful for some of our patients who've got these chronic dizzy problems. And then the third leg of treatment is venlafaxine or an SSRI. But these have to be tailored to an individual. So I can't give individual advice here. But I think what I'd say is I think you need to ask yourself why you don't want to take those medicines. Because you're unwell, and surely you deserve the opportunity to get better. And I would have thought if you're really struggling, you need to speak to your therapist, a physiotherapist, and you need to speak to me or whoever's currently looking after you medically, and just revisit it to see, do we need to concentrate on the vestibular physiotherapy? Do we need to make sure you've not got a secondary problem such as BPPV or migraine? And really encourage you maybe just to revisit the opportunity of having the medicine. So don't suffer in silence. And I think the other message that comes across from your question is the challenge of screen time and immobility. That's the worst thing that you can do for a balance disorder. So again, try and get yourself out, try and do a graduated exercise program, try and walk more and more, maybe go and walk on a beach, maybe walk around a lake, Rutland Water, that sort of thing, to get different sensory stimulations about things that are enjoyable.
Definitely. Okay, next up we've got one from Ken. Ken says he's been told that there isn't a cure for damaged vestibular nerve. Is that true?
Yeah, there isn't a cure for the damage to the nerve itself. That is true, but you can adapt to it. So the vast majority of our patients who have a damaged vestibular nerve will get better through treatment. Brilliant.
So it's not all bad news if you've damaged the nerve.
Absolutely not.
Right. Next up then, we've got a string of questions from Richard. So first up, he's put, what is known by having chronic ongoing BPPV as opposed to having BPPV the once or twice and having the Epley manoeuvre performed and it didn't help?
Yeah, I think that's a really interesting question, and it opens up a really good discussion. So benign positional paroxysmal vertigo, BPPV, is that condition you remember where you get crystals in your inner ear, and classically dizzy when you look up, to the washing line, shelf, when you lie down in bed, roll over in bed or sit up. You spin, you have an Epley manoeuvre, you get better. Nice and easy. But actually it's not as simple as that. Because patients with BPPV get other symptoms as well, which are often not recognized so easily, because you've got these rocks in your inner ear, crystals in your inner ear, which is 6 microns across, but that's 6,000ths of a millimeter, 600,000ths of a millimeter. But the ear can detect nanometer movement. So these are actually really big in terms of the sensory ability of the inner ear. So when you walk, these great big rocks are stimulating the nerves in your inner ear. So they also produce disequilibrium. So it's not just BPPV. So over half of my patients who come to me saying, I'm really dizzy, doctor, I feel unsteady, but I also spin, or they may not even be aware they spin because they prop themselves up in bed to avoid spinning. If I do the Epley manoeuvre, their dizziness gets better as well. So that's one concept of chronic BPPV. But in medical terms, chronic BPPV essentially means you've got it all the time and it doesn't get better. And I've had, certainly when I started up in Leicester 18 years ago, every year I'd have half a dozen people who'd had BPPV for 30 years. I had one that had it for 40 years. In fact, we did a TV program on Doreen from Rutland, who'd had it for 60 years. And she had a combination of BPPV and vestibulopathy, and we did a whole TV thing about it. She did well in the end by treating the BPPV and the balance disorder, and we got her better. So chronic BPPV could be relapsing BPPV. In other words, it keeps coming back, coming back. Or it could be BPPV that's never been properly treated, and it's there all of the time. And essentially, if you've got that, first off, you need to see someone who can do proper Epley and Simont manoeuvres, really vigorous ones to try and shift the crystals. If that doesn't work, we have the TRV chair, or we can throw you around and sort of slam you, if you like, to try and dislodge the crystals. Thirdly, we can try and make sure your vitamin D levels aren't too low. Fourthly, try and prop yourself up in bed. Don't do exercises like Pilates and yoga and sit-ups, which might put the crystals back. And then finally, if you're the 1 in 200 people who have BPPV that's not treatable with any of those, then we can look at surgery. So, yep, some people definitely have very long-term BPPV.
Definitely. Okay, Richard also asked, why don't professionals like his neurologist, ENT, BRT and GP and psychiatrist all be liaising together so that they understand how the physical vestibular illnesses affects us mentally and vice versa, instead of the patients having to chase this up?
Yeah, no, I think it is an issue in some centres that there isn't liaison. We're lucky where we are in that the neurologist sits in with me. Michaela sat in with me for 5 years when I started up here 18 years ago. So we know each other incredibly well, and we talk all the time. You know, we pop in and out of the office all the time to share discussions regarding patients. With neurologists, you know, I speak to them, I'm with them, and I even see patients together with my neurology colleagues to try and work out what's going on. I think the issue is the way medicine is trained. So we're all trained in hospital medicine as specialists, and I'm an ENT surgeon, but I happen to be sort of super specialist in the ear and super specialist in balance. But that's meant that I've had to go out and actively work with colleagues in cardiology and neurology and physiotherapy and all these other groups to learn what they do. And I think that there is a narrowness of training in medicine, which is an issue. And it's not just in the UK, it's the same absolutely all over the world. So if you look at, there's a paper from Florida saying that if someone presents to a physician with dizziness in Florida, it's a few years since I've read it, but I think they'll see an average number of 4 physicians have 1 CT, 1 MRI, take 2 years before they get the diagnosis. So this is a problem all around the world because there aren't many, open quotes, dizzy only specialists. And that's why what we're trying to do is set up balance centres like the one at London Ray Clinic and Leicester Royal Infirmary to try and be more holistic, to look over all the potential elements of balance. But as we said right at the beginning, unsteadiness can be any bodily system. So when I give a lecture on this, I always start by saying, thank you for asking me to talk about the non-ear related causes of dizziness. What I'm essentially going to talk to you about is an entire textbook of general medicine.
Yeah,
that's the challenge.
Yeah, definitely. Richard also follows vestibular migraine and triple PD groups on Facebook and YouTube. And he says, is inflammation in the body a leading cause of vestibular disorders? What are also some of the other main causes? And how long does it usually take to recover and get better from these types of illnesses?
So inflammation in the body, of course. I'm not sure. I don't think so. I think that vestibular migraine is a genetic condition. And for some causes of migraine, we actually know the gene. So hemiplegic migraine, so if you get severe migraine and you're sort of semi-paralyzed down one side of the face, and I saw a comment on the chat about feeling numb or weak on one side of the face, which is a very typical migraine feature. We actually know the gene for that. It's called the CACNA1A gene, which is a calcium channel gene in the body. And it also causes some other conditions, episodic ataxia type 2, where you get episodic spinning, and spinocerebellar ataxia type 6, if you want to be really nerdy. So it produces a range of different conditions. So migraine is primarily caused by, it's underlain by a genetic condition. And triple PD is a combination of a variety of conditions. It's usually caused by an insult to the inner ear. It's more common in those who have a history of anxiety, and it's more common in those who have a history of migraine. And as I've alluded to in our previous research, the structure of your brain, the way your brain is made, predisposes you to PPPD. It's how you react to stress. Now, inflammatory conditions are a physiological stress, just as emotional conditions are psychological stresses. So yeah, inflammatory conditions will predispose to any of these conditions because they put a stress on the body, and stress in any form will make PPPD or migraine worse. But I'm not aware of a specific link with inflammatory markers and migraine or triple PD.
Brilliant. I guess you're the man that would know. So last bit then from Richard is, can some drugs make the dizziness and vestibular symptoms worse in the long run and should be avoided?
Oh yeah, for sure. I think this is a good question again, Richard, and there's been a theme again this afternoon. That drugs that have significant side effects or are powerful vestibular sedatives should definitely not be taken in the long term. And the one we've spoken about several times, of course, is prochlorperazine, Stemetil, because A, it suppresses your balance function, and B, it can lead on to Parkinsonian type symptoms. So we would really want you off the medication, whatever it is, in the long term. There are some drugs where I'm fairly relaxed about you having it longer term. Amitriptyline for migraine, I'm pretty relaxed about. Some people are on propranolol for a fair amount of time, although they can make you quite tired. And some of the SSRI antidepressants, although we try and limit them to 12 months for PPPD, can be taken long term if needed. And Snarazine, again, I don't want you on long term, but it's a useful drug to be on medium term. Beta histine, Circ, is the one for Meniere's disease that people do take very long term, but it's a very mild medicine. And actually, I don't use it very much now at all because the evidence is not strong for its use in Meniere's disease.
Okay, we are on our final question on our list of fabulous questions today. So the final honour goes to Carolyn, and she's put, one of her balance issues is when she needs to concentrate, whether reading a book or on her phone or concentrating generally, she can become much more imbalanced, which can last for quite a long time. She calls it brain fog, but it's maybe not the right terminology. Why does this happen?
Yeah, it's another great question. And I have to say to everybody, I'm just gobsmacked by the questions today. They're absolutely brilliant questions. And I've truly enjoyed talking through them all. I hope it's been helpful. But the answer to your, thank you. The answer to your question goes back to my sort of slightly graphic description of the copper wires that carry bundles of information from your eye to your brain. So if you're reading, scrolling on a computer screen, in a shop, you're on a train with the windows going, there's an image going past you, you've got light across the road, all of these things. Many of us will note that information change and process it. But if you've got vestibular migraine or certain other conditions, PPPD and so on, you overweight that information. So when that information blob comes in, that bite of information, the brain lights it up as being really important. And it overloads the balance part of the brain. And that can also happen with other stresses, because stress by its very nature heightens your alertness to any sensory signal that comes in. And that's tiring for the brain, because you must remember your brain is no different to a muscle. And if I went and did a half marathon, I probably wouldn't walk for about a month now. And that's the same with your brain, because if your brain gets this sensory overload from emotional stress or from visual cues, then it takes a long time to recover because you're using brain energy. And a really nice analogy for that is, I'll take you back a year or 10, depending on who you are, to your school days. And can you remember when you did exams, you'd go home and say, oh, I've got brain ache. Well, actually, it's no different, is it, to getting muscle strain when you're running that half marathon? Because your brain is an organ that needs caring for and cherishing. And that's why you need to eat well, sleep well, exercise well, and live well to look after your body and look after your brain. I sound a bit like a missionary, but you know,
it's so true.
My father-in-law is a missionary, so anyway. That's what you need to do, and if you look after your body, it will help many of the symptoms that you may have.
Definitely. Excellent. I think that's a really nice note to finish on with our questions today. So thank you, Peter. Obviously, because I've been up front asking you the questions, I've not been doing my other normal job today of monitoring the chat. So, Kevin, what's been going on there? Are there any time?
Yeah, there's a few. I think if you don't mind, Peter, if we've got sort of 5 minutes to play with.
Yeah, sure.
It's possible on Zoom, if you know how to use the reactions, you can, if you've got a question, anyone, you can raise your hand electronically. We'll try and come to you. If you can't do that, you can use the old-fashioned method of raising your hand. So
I don't know how to take it down now. I've done it.
I'll try and do that for you. So if you'd like to have a look on the gallery view, Kelly, and just go to anyone. I can see a lot of hands raised already.
Before I put a couple of answers up during the tea break. Probably easier if I'll turn that off. I'll listen to the questions.
Yeah, I think Michaela's also been answering. So I think some of them, I can't see the chat at the moment. I've got Mary, your hand up for a question. Mary, you're on mute.
Yeah, take yourself off mute to give your question and then put yourself back on as soon as you've asked it, please. See that?
No, she's talking, but there's no sound, Mary. You've got to take it off mute now. Hey, oh. Go on, give it another go.
Come on, Ella. No, she's not done it. No, she's still on mute.
No, Mary, we might come back to you.
We'll come back to you, Ella.
See if you can figure it out.
Yeah.
Who else? I'm not seeing. Oh, Sandy's got a question. Sandy, can you take yourself off mute? Fabulous. What's your question for Peter Ray?
I put it in the chat box, but I've had times where what people have told me, I have dizzy brain. I don't have room spins. I just have it in my brain. I also have head tremors, which doesn't help. I couldn't do PT because my eye movements were not working with, it was a catch-22. But anyway, recently my symptoms have been coming and going. I can wake up in the morning and feel okay, still have the brain fog and the out of it kind of thing, but the dizzy brain is not there, which makes me ill, very ill. And I the first time it happened, it was like, wow, where'd it go? And then it came back and I'm like, what's up with this? Now, how does it come and go? Because I have had it where in the afternoon, it will all of a sudden hit me like a lead balloon. It'll be there.
That's a really good question. It's something that will be shared by a lot of the other people listening today. I mean, I think there's a couple of things to say. Firstly, if your eye movements are all over the place, it's clearly important that you've seen a neurologist and you haven't got a central balance disorder. And that goes without saying. But actually, fluctuating symptoms with vestibular disorders are a hallmark of vestibular disorders. And it goes back very much to what I was describing about the impact of other stresses, be they psychological or physiological. So in other words, the emotional strain that your brain has to handle, or the physical strain from sleeplessness, jet lag, intercurrent illness. Your brain, when you've got a balance disorder, is working at the edge of its capacity, like you running that half marathon, and it's just as far as you can run. You put some additional stress on it. You had a bad night's sleep, you had a row with someone in the shop, all of these things. And then that will be just too much for your brain to process. So that's how we conceptualize it, that it's a sensory overload phenomena. And that then is how you describe brain fog and all the other symptoms that you describe. So we sort of understand, we think what's happening doesn't necessarily mean we know well how to treat it.
Brilliant. Thank you for that, Peter. And thank you, Sandy, for your question. I can't see any other hands.
Amy, Nicola,
there is no. Kelly, you might have to look on a second screen because we've got so many.
Should I say John?
Yeah, John, do you want to ask yours, please?
Yeah. Can you hear me?
Yeah, hi there.
Yeah.
Professor, thanks very much for talking to me and appreciate what you said before about the bilateral vestibular loss. Just two little points. Mine first started in February 2020, around the same time as COVID hit. Before that, I was very physically active. Used to run 5K 4 times a week. And it was around the time that COVID hit. I was never tested because there was no testing in the early days. Because what's happened with me is my symptoms have got worse over the last 2 years from that point. I started off with having vertigo that was like 30 seconds long, and now it's virtually at the point where I just feel it for a second and it goes. Just wonder what your thoughts were on that, please.
Okay, I think that's a really valuable question, and it's one of the commonest questions that I'm asked in clinic at the moment. Now, we've done a lot of research in Leicester. I'm not quite sure why so much of the work's been done in Leicester, but we seem to have done a huge amount of the balance and COVID work here. And we started by taking samples of patients' noses who had COVID. And we have some fabulous pictures and these are patients who survived. We've actually got pictures of the COVID virus entering the cells, the hair cells in the lining of the nose, and then destroying the lining of the nose. So that we know happens. We've then taken, I wanted to take samples from the ears of patients with COVID because I imagined that we'd get a lot more patients with ear infections caused by COVID, but it didn't happen. And we've done another research which has shown that the number of infections collapsed during COVID. So very, very few. So the only way we could get the samples, and this is a little bit squeamish if everyone's okay with it, but we had to go to the mortuary and take samples from patients who died of COVID. And we had, of course, large numbers last year and the year before. And we haven't published the results, but they should be published very soon. And we've shown in the only UK study that we actually have quite large numbers of COVID viruses in the ear as well. Now, it's a bit of a long-winded way of answering your question, but there's three potential explanations to your question. The first is COVID has nothing to do with this, nothing to do with your problem, and it was something else that caused it, because people do get acute bilateral vestibular failure from a wide range of different causes. Secondly, the COVID has entered your inner ear and destroyed your inner ears, the balance organ in there. And there is no question, I've seen large numbers of patients with dizziness and hearing loss, severe hearing loss, and huge numbers of patients with tinnitus following COVID. And I think this is a real thing, I think. So the second thing is it may have gone in and damaged your inner ear, but thankfully we're not allowed to go into people's ears to sample them when they're alive, because that's an unhealthy thing to do. And we haven't been allowed to go into people who have died into their inner ears because that causes drilling. And if I've had COVID, that would spray virus all over the people doing it. So it's actually very difficult research to do. And then the third possibility is reflecting back to knowing that the virus goes into your nose and can probably go up the nerves. It's possible that you've had an inflammatory process in the brain affecting both of your ears, causing chronic dizziness as well. Now, if you've had caloric testing and investigations which show that you've had peripheral vestibular hypofunction, ear function, it's most likely, if this is a viral origin, because it's on both sides, and assuming it wasn't a head injury or a drug toxin, and it's COVID or a similar virus that's destroyed the inner ear balance function on both sides. And we've seen it, and it's happening. And the recovery period from the dizziness, we would hope would be, excuse me, sorry. We would hope would be over a period of 18 months or so. But it can be interrupted by conditions like BPPV, the crystals in the inner ear, which makes recovery worse. And I suspect is what's happened, may have happened with you.
Brilliant, thank you for that.
Can you see them now, Kelly?
No, I can't see the reaction.
Nicola.
Tracy. Nicola.
Tracy, sorry.
Nicola, go for it.
Nicola, go on.
Yeah. I've had BPPD diagnosed from yourself since last 5 years, so I've always got a slight dizziness in the back of my head. And travel is becoming a problem because I've never been on a boat since, because I just feared that being on a boat make me seriously unwell, because even when I travel on a plane, just going 4 hours to Greece, when I get off, I'm a lot more dizzy. It's like I have been on a boat, and I've had to give up skiing and anything with emotion moving like that, because when I did try skiing, I come back, it took me months to come back down to some kind of basic dizziness rather than full-blown dizziness. So is there anything I can do to help me with travel? Because I say I've had to change any kind of enjoyment as regards doing anything with emotion in it. And I don't know, is it more than PPPD? Because obviously a boat is just a no-go.
Yeah, I mean, it probably is triple PD primarily. I mean, whether or not you've got vestibulopathy, I can't recall with that as well. But all of these conditions can be aggravated by certain situations. There's no question of it. And this is this concept we got over when we were talking about Malders-Bachmann syndrome, is that I'm slightly uncomfortable with a discrete diagnosis of triple PD, Malders-Bachmann. I think there's a spectrum of otological dysfunction. In other words, there's a spectrum of how the brain handles balance function. And I think that we can't compartmentalize it as a single. We do compartmentalize it because it makes medicine and research easier. But I think in the real world, that's actually not what's going on. And, you know, there can be emotional elements to it as well. So your brain fears that you're going to get that. It may be there's a migrance element to it that can do that. But what I recommend to you is what I recommended earlier in the session today. And that is take a vestibular sedative, Cenarizine, for your trip, or even take a sleeping tablet if someone's allowed to give that to you, like diazepam, for the journey. Wear headphones for the journey so the sound is cut out, and wear a mask so you don't get visual stimulation. Don't use screens and computers on the journey, and try and find a way of traveling that is least stressful. And I thought that Kelly's suggestion of telling the airline was an absolutely brilliant one. I've never said that to patients before, and I think I will say it now. And, you know, if you fly rather than a boat, maybe get your own transfer at the other end.
Yeah, that's what I have to do. I can't go on a coach. I can't sit at the back of the coach. I've got to be in a horizon point at the front.
Yeah, exactly. Or remember, horizon points are good, but so's closing your eyes. Because what the difficulty is the visual triggers. So if you're looking out the side like this, as opposed to looking at the horizon in front, that'll make you really sick. Looking at the horizon is good, but putting a blindfold on is also good, because you don't then get the visual. You don't get the visual triggers. Sorry, my computer's doing something funny up here. You don't get the visual triggers, and I think that range of tricks is important. And look after yourself. So, you know, when you're on the ski holiday, don't have be careful what you do with what you eat as well.
Yeah. Okay, lovely. Thank you very much.
Great. Tracy now. We can't see you, Tracy, but hopefully you can hear us. If you can ask your question.
Yeah. I promise I'm here. My camera's on. It's just not working.
No problem.
Maybe it's because I didn't put makeup on or something. The camera can't cope. Thank you, Peter. This has been brilliant. I've literally got 4 pages of notes. I've learned so much just from the last couple of hours, so I really appreciate it. My question was around diagnosis. So I have literally on the report, it says the diagnosis is a bit of PPPD, a bit of Meniere's, a bit of MDDS, a bit of BPPV. And there's, I appreciate what you're saying about dizziness being a symptom, so we've got to work out what the problem is. But do you think it's worth me pursuing a clearer diagnosis or not, is my question.
Yes. Yeah, I think so. You've got quite a lot of that. Now, I mean, having said that, you know, Meniere's disease, when I'm teaching, I'll always say Meniere's disease is 5 conditions in one. So of my patients who have Meniere's disease, 40% have migraine, 20% have BPPV, all have a degree of vestibulopathy, and maybe that can morph into triple PD, and all have a degree of stress and anxiety with it, because who wouldn't, because it's horrible. So yeah, there is overlap, and to get Meniere's and BPPV together is really common. And if that's led on to a chronic symptomatology, I mean, I think diagnosing MDDS and PPPD and BPPV is a bit of a alphabet spaghetti, isn't it? I would tend to try and narrow it down. Now, I am a believer in trying to get discrete diagnoses, because there's 2 ways of managing balance. You can either say, you're dizzy, let's treat the dizziness. And that's really how we sometimes treat much older patients who are a little unsteady, maybe start need to walking frame, want to make our patients safe. And it can be a whole range of, you know, orthopedic and cardiovascular causes and so on. And that's not unreasonable. But you sound younger, and for younger patients, you want a discrete diagnosis, because the treatment for each of the, if we look at the the Meniere's, we've got fabulous treatments for. The paper that I co-authored in The Lancet in 2016 with intratympanic steroids, you know, we've got a 90% reduction in vertigo attacks with that treatment, and it's almost risk-free, but sore sometimes, but almost risk-free. And we have other treatments if that doesn't work. But BPPV, we can get nearly everybody better. For sure, I can't stop my patients getting relapses, and that's for a small group of my patients, and some of whom I'm quite sure are watching, but I know are watching today. That's a really difficult position. But, you know, we can try and treat it as best we can. And then for triple PD, we have medications and a range of other therapies that we can use as well. So I would absolutely urge you to see someone to try and clarify the diagnostic boundaries and get you a treatment protocol for each element. Yeah.
Okay, thank you.
Good. Right, Peter, we've got 5 questions left to go through. So we're going to have to be really, really fast. And those giving the questions, try and be as brief as you can. Amy, if you could go next, please.
Hi, thank you, Peter. This is really helpful. I've got Meniere's and vestibular migraine. My ENT is pretty sure that it's the migraine that's powering my symptoms at the moment. He wants me to try doing vestibular rehabilitation exercises again, not with a therapist, because no, you know, with COVID, it's such a long time to see, but I did do this over a decade ago, so I still have the exercises from them. He wants me to try it again. Since both my conditions kind of merged to create lots of symptoms together, doing anything like that, repetitive head motion, has made me a lot worse. So I'm a bit worried about going ahead and doing it. And I've also read if some places say that if you have migraine, doing the rehabilitation will just make things worse. Some disagree with that. So what would you recommend?
Yeah, no, it's a really good question. So vestibular migraine can, for those who aren't so familiar with it, can cause the acute vertigo, which is really distressing, and migraines, headaches, if they're there as well. But it also causes chronic imbalance. So when we have the migraines under reasonable control, there is a rationale for doing vestibular physiotherapy, and I'll ask my patients to do that. But if you're having severe attacks, as you are at the moment, I wouldn't do vestibular physiotherapy. It'll just make you feel terrible. I think you need to try and get
at the moment, my spins, if I do all the right thing, don't push myself too much, avoid much repetitive movement, my spins are more internal than external, you know, like with the eye rolling and, you know, like the more Meniere's, it's more everything. It's like I'm standing on the turntable and so is the whole world, and everything's turning rather than the room spinning.
Yeah, but look, if you're in that situation where you're getting, it doesn't, again, going back to the International Headache Society diagnostic criteria for vestibular migraine, internal and external spins are recognised equally as a symptom of vestibular migraine.
Okay.
You know, I would be looking to, if your migraines are that bad, I presume you're under a neurologist for that as well.
Neurologist and DNT, but no one knows what to do with me. It's been 4 years now.
Yeah, no, it's a real challenge. I think you spoke last time, didn't you?
Yeah.
You asked an absolutely beautiful question, I remember last time, so thank you for that. And I think it's a real challenge. And, you know, it's a matter of, you know, trying to get those migraines under control. You heard Louisa Murden is a great expert in London on migraines. Louisa's really lovely as well. And, you know, I don't think vestibular physiotherapy is a good thing to do when you're having internal and external spins, because it'll just make you feel rubbish.
Okay, thank you very much.
All right.
Lovely. We've got Naomi. If you can ask your question, please. Naomi?
Hi, yeah, mine was just about changes in anger and rage symptoms. I don't know if that's normal with vestibular migraines or if that's got to do with the propranolol I'm on. And also, I did ask before, I think 2 meetings ago, about so not being able to move or talk and just like staring in one space, and this can be from like a minute to 20 minutes. Obviously, I'm trying to get a referral to a neurologist, but I just wanted to see if last time only one person thought that was only happened to one person in the group, so I don't know.
Yeah, that sounds really unpleasant, doesn't it? So, I mean, propranolol shouldn't be associated with anger and rage. In fact, it's a treatment for anxiety. It can make some people feel tired, and there's no doubt that, you know, anger and sort of psychological issues will drive vestibular migraine. So if you're got those type of problems, your migraine is, you know, stress, in other words, it's likely to be quite a big driver of migraine. And absence sensations where you're feeling dissociated or quiet or can't speak for a minute or 3, there are a range of different things that can cause that. Some ranging from seizures to, again, psychological conditions. So that's absolutely something that is best. Oh, we can see you now. Hello. That is something that's best managed by a neurologist for sure, because that's not going to be a vestibular symptom.
Okay, and so the new anger and rage is, I'm talking about new because I'm not usually an angry person. That's probably, again, for the neurologist. Oh,
absolutely. I think as an ENT surgeon, that's not something I'd explore. And it may not even be something that the neurologist can explore.
Okay.
They may need to go down a psychological or psychiatric route to try and get to the bottom of what that is. But you would certainly go and see, if you're having absence episodes, you would certainly go and see a neurologist first, see what they say, and then they may or may not guide you down other routes. Yeah.
Okay, amazing. Thank you.
Great. Two left, Peter. Debbie Lou, can we have your question, please?
Yeah. Sometimes when I'm standing, talking to someone, cooking, watching TV, can feel fine. And then all of a sudden I get a huge spin, which literally is like someone pushing me over. Is that indicative of BPPD or V or?
One of those. It could, yeah. I mean, that's really frightening, and that's actually quite a common presentation to the Balance Clinic. That symptom, and it's actually quite a difficult one to get a diagnosis in. It certainly can be BPPV. Now, BPPV classically, as we've said, is spinning, lying down, rolling over, looking up. But in the kitchen, you're bending down, you're looking up at your pots and so on. So BPPV would be top of the checklist to look at. But there's an awful lot of other things to look at there, from heart rhythm to blood pressure to migraine to Meniere's to just a whole range of conditions to look at. So yes, it could be BPPV. BPPV is common, affects 1 in 100 people. Vestibular migraine is common, affects 1 in 100 people. But those other conditions are much less common, and it can be quite hard work actually exploring to try and identify the cause of the symptoms you've got there. I mean, it can even be vestibulopathy, in other words, weakness of inner ear function from a viral infection of your inner ear, and then you make a certain head movement and your brain can't compensate to it as you're turning in the kitchen. The kitchen and the shower are two places that people often report those symptoms. So that's something that we definitely need looking into, and almost certainly need balance tests to try and work out what's going on.
Brilliant. Last question now, Peter, is Richard's iPhone. If Richard is there, can Richard join us?
Hi, Peter.
Hi.
Hi. Thanks for your help today.
Phone a bit lower, Richard. We can
only see your blind.
The phone is charging.
We're nearly there. That's it. Oh, yeah, we've got you. Thank you.
Yeah. Hi, Peter. I was going to ask you what is meant by migraine with brainstem aura.
Okay, so that's a fair question. It's a sort of slightly older term, but it's a really important concept. So migraine can affect different parts of your brain. So it's not a depolarization of the whole brain. So people will, outside this forum, will think of migraine as something that causes really bad headaches, pulsating unilateral headache. Yeah, and of course, that's one of the symptoms of migraine. But some people's migraine is visual aura. So they get zigzag lines or flashing lights, and that makes up 20% of migraine. Some people's migraine is dizziness, and that makes up 10% of migraine. And we've said that some people's migraine, particularly in children, can be blank attacks falling to the ground, can be knee pain, can be abdominal pain. And posterior fossa migraine or brainstem migraine often is associated with some of the symptoms that we've been discussing today with dizziness. So it implies that the depolarization or the abnormality the electrical focus of migraine is back here at a very primitive part of the brain, and that can be associated with a range of symptoms, amazingly, including hearing loss and tinnitus. Now do you see the problem? That we then get patients diagnosed with Meniere's disease because they have a transient low frequency hearing loss and tinnitus and dizziness, when actually it's migraine. So that's what it is. It's a subgroup, brainstem, if you like, posterior fossa, whatever you want to call it. Brainstem migraine is one subgroup of migraine that presents with some of the symptoms that we've been discussing today.
Lovely. Thank you very much. That you'll be pleased to know, Peter, we've run out of questions today.
I've run out of voice.
Yes,
that is a record.
That's our longest meeting, biggest audience. I have to say, Professor Ray, thank you so much for giving up your free time for us bunch of dizzies for this 2 hours is amazing. Really good of you. just to everyone out there, remember this has been videoed, so you'll be able to go over it again if you missed any points. There'll also be a copy of the chat transcript available on the website as well. All this in a few days. And as we always say, Press for 8, all of this being recorded is going to help so many people in the future as well. So it's really great. Thanks for everyone. Your questions have been amazing.
I agree.
Yeah, outstanding. And I think all I can ask is one quick round of applause for Professor Ray's work today, because I think he's just been superb. So thank you very much. Thanks, Kelly, for putting all those questions. Been really good. We'll all be back Saturday, the 23rd of April, and there'll be more details. One last thing to forget, just technically, a lot of people are getting emails going into their spam folders from us. Do check spam folders and try and do something called whitelist us, so our emails always come into your inbox. But thanks, everyone. Thank you very much, Peter. It's been a brilliant meeting, and I hope it goes on to help all of you. And remember, keep the hope there. Things will get better. But thanks once again, and we'll see you all in.
Have a good weekend, everyone. Bye.
Thank you very much. Bye-bye. Bye-bye. Bye.